Recording. All right, so welcome to Implementing Outpatient Antibiotic Stewardship. I am Emily Perry. I am the Antimicrobial Stewardship Pharmacist with the CAP Center at NDSU and the Antimicrobial Stewardship Lead for North Dakota's Health and Human Services HAI-AR program. These are my disclosures. It's not much. And then, so for our content for today, as you know, this is a three-part series where we will be going through and working through the history of stewardship, the importance of stewardship. We're going to talk about the core elements. We're going to talk about some barriers. And since it's a three-part series, we're also going to have a little bit of homework on building a stewardship intervention within your facility. We'll get more into that at the end, and trust me, it won't be that much work for you to do. All right, so to begin with, we're going to talk about the history of antimicrobial stewardship. It really started back in 2004. The Infectious Disease Society of America sent a white paper, Bad Bugs, No Drugs, to Capitol Hill, really stressing the importance of this growing public health crisis in the emergence of bacteria that were resistant to many antibiotics. From that, the IDSA decided that in 2010 they were going to make a goal of having 10 new antibiotics to the market by 2020, which they did actually achieve that goal. This then was followed by the CDC publishing an antibiotic resistance threat report for the United States in 2013, which prompted President Obama in 2014 to send out an executive order and a national action plan that was directed the Department of Health and Human Services to really review existing regulations and propose new regulations and actions that require hospitals and other inpatient healthcare facilities to implement robust antibiotic stewardship programs that adhere to best practices set by the CDC. So because of that, in 2017, Joint Commission and CMS released core elements and participation rules to the facilities in the United States. And that really kind of sparked stewardship efforts in a lot of our facilities nationwide. So why is stewardship really important in the outpatient setting? Well, because most of our antibiotics are actually prescribed in there. So 80 to 90% of all antibiotics are consumed by outpatients, and at least 30% of those outpatient antibiotics are truly unnecessary. And when we dig into acute respiratory infections, 50% of antibiotics given for them are truly unnecessary. And when you think about the cost of antibiotics, over 10.7 billion are spent annually on outpatient antibiotics. So that is a lot of money and a lot of antibiotics being used. And when we dive into looking at like highest use versus lowest use states, highest use states use 5 times more antibiotics than low use states. In North Dakota, we rank 17th out of 50 states for our antibiotic outpatient prescriptions, which isn't horrible, but it's not the best either. And in 2023, we had 669 antibiotic prescriptions per 1,000 patient population. So like 60 some percent of our patients, our population, were getting an antibiotic. So that is a lot of antibiotics being used. And this is a trend of where we are prescribing and the amount we're prescribing over the years. So in 2019 to 2020, we saw a great big dip that was partly due to COVID. Patients not coming into the physician's office, they're staying home, we weren't going out, so we weren't getting those respiratory infections and we weren't getting the antibiotics either. But since then, we have slowly increased our antibiotic use over time. And so our goal is really to slow that progression and slow that increased use of antibiotics. When we break this number down even further, into the classes that we're using of antibiotics across North Dakota, I'm not really unhappy about the way our breakdown is. We can see that our highest use is beta-lactams, which actually is really a good thing to see. that's the most being used because they're more narrow spectrum and they actually are our first line agents for a lot of our outpatient infections. So I like to see that that is our highest use. I would just like to see overall our antibiotic use come down. So let's focus on stewardship to hopefully reduce some of that antibiotic use. So antibiotic stewardship is really the effort to measure and improve how antibiotics are prescribed by clinicians and used by patients. They're in the antibiotic world, we talk about the 5 Ds of antibiotic stewardship, which includes making sure we have the right diagnosis, the right drug at the right or correct dose, that we de-escalate once our cultures are back, and that we treat for the correct duration. There was a study that was published in 2021 that reviewed guideline-based durations versus what physicians were actually prescribing. And what they found was that they used common indications like pharyngitis, sinusitis, acute otitis media, and like urinary or acute cystitis, which, the duration can be 1 to 7 days. We can look at cellulitis, which for adults we should treat for 5 days. But when they looked at what prescribers were actually prescribing, the median course in duration was 10 days. For no matter what indication, it was always 10 days of antibiotics. So you can see that this is a great area. If you're looking for an intervention at your facility, is looking at how long are your prescribers prescribing antibiotics for? Does it match guidelines, or is that an area of improvement? So when we talked a little bit about how the CDC put out core elements of antimicrobial stewardship in 2017, when they did that, it was mostly focused on hospital stewardship. But since that, they have expanded their core elements to include low resource, rural settings, outpatient settings, ambulatory. So they have combined their 7 for hospital down to 4 for ambulatory stewardship. Now they're basically the same. They just combined a couple of the elements into 4 instead of 7. So the first one is commitment, and that's making sure that we demonstrate dedication and accountability for our antibiotic prescribing. The second one is action for policy and practice, making sure that we are doing something and that we have a purpose and that we are focusing on stewardship. Tracking and reporting is our third element. It's basically monitoring our antibiotic practices and often giving feedback so we know what we are prescribing. And then educating and having and utilizing expertise, whether that is, farming out to infectious disease or educating clinicians or educating patients, those are all the core elements. So in the outpatient world, there is some evidence-based strategies that have been shown to work really well. Patient education and clinician education are some strategies to think about and that have worked in the outpatient to help lower antibiotic use. Peer comparison, we'll go over that in a little bit. Clinical decision support, having whether that is having a decision help in your EMR or if that's a PDF that you use, having some type of clinical decision support for your the providers, having written justification of why they're using antibiotics or requiring indications on prescriptions have been shown to help lower antibiotic use. Public pre-commitment and communication training have all been evidence-based strategies that have worked in the outpatient setting. Some general principles to think about is that successful strategies may not be the same as in the hospital. Education is necessary, but is not sufficient. So you can't just say, oh, our action is going to be that we're going to educate our providers about antibiotics. Well, that only goes so far. They'll remember that for a day, but you really have to go beyond. So a stewardship intervention would be something like, we're going to educate our staff and physicians on the appropriate durations for treatment of UTIs, and then set in a policy that we're going to treat uncomplicated UTIs for only 5 days per guideline. That would be a way of educating and making it an intervention. And then just reminder that change is possible, but sustained change over time can be difficult, and that's where the commitment and having a leader really does help. So let's talk about some strategies that may work in a hospital, but may not work in the outpatient setting. So in the hospital, a lot of times stewardship committees will restrict targeted antimicrobials, whether those are, your broad spectrum antibiotics or your really expensive ones, or sometimes antifungals are restricted. That works well in a hospital setting where they can have a formulary, they can have policies on that. But in an outpatient setting, it's hard to tell a doc that they can't write for a certain antibiotic. That's a lot harder to do. So it doesn't really work well in an outpatient setting. It might work well for cost control. Basically, the insurance comes back and says, you can't use that antibiotic or they won't cover that antibiotic. So those kind of things happen in the outpatient setting, but really restricting what a physician in an outpatient setting can write for doesn't really work well. Another strategy in the hospital is prospective audit and feedback. And that one is where a lot of times it's a pharmacist that will review antibiotic orders after the provider has written them. And they'll double check, is this appropriate for the indication? Is the dose correct? Is there a different antibiotic that we should be using? Did cultures come back and now we need to readjust our therapy? So that works well in a hospital where you can have someone do that, and where if you have to change therapy from 8 a.m. to noon, you've got cultures back and you can change the antibiotic. You can do that really quickly. In the outpatient, if you have to change an antibiotic for your patient, they may not be very happy about that because then might have already picked up their antibiotic and they're going to have to pay another copay. They have another trip to their pharmacy. They may not appreciate that. So that type of perspective audit and feedback really doesn't work in that outpatient setting. A third strategy in hospitals is clinical algorithms or pathways. So this is basically saying we'll use pneumonia as an example. For pneumonia, we're going to treat with, first line is going to be ceftriaxone and azithromycin, or ceftriaxone doxycycline for community-acquired pneumonias that are hospitalized. And then you can have a pathway and say, after 2 days, we're switching to oral. That does work really well in hospital, but it can work in outpatient as well. You can set up pathways on disease states with they can be in a PDF, they can be built into your EMR that would work, that says for this diagnosis, these are our first line agents. This is what works with our antibiogram, and you can help drive appropriate therapy based on algorithms. And you can put that into your EHR, into those clinical-based decision support methods as well, and that works for the outpatient. Things that work really well or that are benefits in the outpatient versus in the hospital is when we're tracking our antibiotic use, we can dive down and tie antibiotic prescribing directly to the specific clinician. It's virtually impossible to do in a hospital setting because they're rounding on different patients, their teams get changed, they'll start an antibiotic in the ER, get moved to a unit, and then who continued that antibiotic, it changes often. But on the outpatient side, a doctor writes for a script and you have that doctor's name on that script. So you can really tie back their antibiotic prescribing to the clinician that wrote it. So that's an advantage. Also, in the outpatient setting, a few diagnoses actually account for most of the outpatient antibiotic prescriptions. So you can have more impact targeting one specific condition. Also, there's usually a large number of cases, so it makes it easier to have and study an impact of your interventions. I know, usually it seems like when you get one case of otitis media, then you get 5 cases of otitis media in a same day. So it's really nice that you can make an intervention and you can see it and track it really easily in an outpatient setting. All right, so our next thing is going to be a discussion time. And I'm going to pause One way to look at and display commitment is maybe having a sign in your facility in one of the patient's rooms that says, you're committed to stewardship. That's an option. Commitment is really important. And it's important to identify a leader that's going to be committed to following up and making sure your intervention works. So whether that's you or somebody else in the facility, it's really important to have a leader. And then really another thing is to assign their stewardship duties within their job description or talk about it on their job eval so that they know that there's follow-up coming about the job that they're doing. And it's important to have someone that can communicate with all your staff members, not just your providers. And so I talked a little bit about hanging a sign for commitment. And here's an example of why that works. There was a study done in 2014 that looked at using little nudges based on public commitment, so these signs. And they did this in 5 different primary care clinics. They had roughly 1,000 adults that had acute respiratory infections during their study time period. And it was about half that were treated in a facility that had these signs showing that they were committed to appropriate antibiotic use. And half were treated in clinics that did not post these signs. And what they found was there was a 36% lower rate of inappropriate prescribing for viral respiratory tract infections. Now, this is a good thing to have, not only for your patients to see that you're committed, but also as a good little reminder for your physicians that they don't have to prescribe antibiotics or feel that pressure to prescribe. So just an easy, simple thing of hanging this in a patient's exam room is a really good way to have an intervention. And I don't know about anybody else, but when you're sitting in those exam rooms waiting for a provider, it gives the patient something to read. We can no longer have magazines in those exam rooms. So having this on the wall and maybe even having next to it when to treat bacterial versus viral poster might also grab their attention and make them think about maybe not pressuring their providers into an antibiotic for them. So the next core element we are going to talk about is action. And action is making sure that we have at least one action to improve antibiotic prescribing that is measurable. And some of these opportunities that we can do for action include some of CDC's high priority conditions for improving antibiotic prescribing, which include conditions that antibiotics are often overprescribed, such as for acute bronchitis or non-specific upper respiratory infections or viral pharyngitis. Also conditions for which antibiotics might be appropriate but are overdiagnosed, such as when we're going to treat for a strep pharyngitis, but there is no diagnostic test that's positive for group A strep, or conditions for which antibiotics might be indicated, but which we picked the wrong dose, or agent, or duration, such as using azithromycin versus amoxicillin or amoxiclav for acute uncomplicated bacterial sinusitis. And another high priority condition is using watchful waiting or delayed prescribing, especially in uncomplicated sinusitis or acute otitis media. So those are some examples of times where we could implement a stewardship intervention. Other actions include providing communication skills training for clinicians and staff on how do I address the pressures I feel from patients when they think they need an antibiotic. Also, we could maybe require indications on all antibiotic prescriptions. It helps them really think about why they're prescribing the antibiotic, or putting in clinical decision guidelines as well, like we talked about. There was a study in 2016 that looked at the effects of behavioral interventions on inappropriate antibiotic prescribing among primary care practices. And their Um, what this study did was three different arms, and they had three different interventions. The first intervention they did was suggest alternatives. So within the EHR, they had an order set, basically like for CAP. Or maybe actually CAP, I don't think it was CAP. I think it was the bronchitis. And what they did was you click on, oh, bronchitis, but instead of having antibiotics listed for treatment, they had non-antibiotic treatments available, suggesting that those would be your first line. The second thing they did was having accountable justification. So they put in free text box for the indications for antibiotics. And then the third thing they did was do peer comparisons. So they emailed clinicians comparing prescribing rates with top performers at their facility. And what they found was that in each intervention, there was decreased prescribing rates in all three. The interesting part was after a year, they went back and they had removed some of those EHR um, interventions. And what they found out was that if they didn't keep the intervention in place, the antibiotic prescribing went back up. So that's where change is possible, but sustainability is hard. So you have to keep these in place. Like whatever you do, you'll have to keep working on it and keep mentioning it and bringing it back up that is what you're working on. And then once you do decide on which intervention you're going to do, tracking and reporting is really important. It's important to assess for potential overuse and know whether you're making a difference with your intervention or not. There's practice level data and there is prescriber level data. Practice level is sometimes easier to determine, and it's not as controversial, and you won't have probably as much negative feedback as prescriber level data or like peer comparison. So practice level that determines like target for improvement for your entire practice, a team type approach. You want to track the progress of your intervention over time and then make sure you're presenting it to everyone that's involved. Prescriber level data is more peer comparison, and we'll talk about that in just one moment. When you're doing your practice level reporting, make sure your reports are simple and easy to understand, that they're presented by the stewardship lead or whoever you have decided that's accountable for stewardship, and make sure that you continually give the data at regular intervals so it's always in their mind. And then always thank them or show messages of appreciation that they are working on this stewardship intervention with you. Now, talking about peer comparison, this gets a little bit trickier, especially if you're in a smaller facility where there may be only 1 to 3 providers. Maybe this one isn't the best route, then the practice level would be a better way of tracking and reporting your antibiotic use. If you're going to do peer comparison, make sure you do get your clinicians involved and find out what they want to know or how they want it presented to them so that they feel engaged and not attacked. One example of how to do this is doing top performers, like, oh, you're in the top 10% of antibiotic providers, which means that they're prescribing less antibiotics than others. And you want to make sure if you're going to do this route that we de-identify so no one can tell which prescriber is which prescriber when you're sending out peer comparisons. The challenges of this is you have to make sure you're comparing apples to apples, that your data is being attributed to each provider accurately. Whatever tool you have and that you're using, you'll have to validate it, and then you'll have to monitor really for any types of changes that may occur, like such as ICD-10 coding changes. So some other tips, it's really important that you do present your data in a ratio or a rate. So basically like review antibiotic prescribed versus number of clinic visits. And where your numerator would be the number of antibiotics prescribed and your denominator would be the number of clinic visits so that you can make it comparable for each provider. So this is an example of one facility, how they recorded their data, and they looked at antibiotics prescriptions per 100 visits with acute respiratory infections. And this is from 2019 through 2020. And they did it monthly, the number of antibiotics and which class of antibiotics was prescribed. I think this is kind of neat to see a trend, what was prescribed and what's not prescribed. But I think another thing that would be neat on here would be to know if any interventions were started. Just flagging like, oh, let's say here in June of 2020, we decided to have, a pop-up alert or so, something that we changed, and you put it in there and then you can see what your intervention did for your rates of antibiotic prescribing. The next core element is education and expertise. It's important that we do use effective communication strategies to not only educate our patients, but also our providers and our clinic staff so they understand information around antibiotic stewardship as well. And not only just talk about antibiotics, but when they are and aren't needed, what the harms are as well. The antibiotics aren't always the safest choice. And then provide them with patient education because, as we know, our patients don't always remember everything we tell them from a visit, but if they're able to have something in their hand that they can read at a later date, that's always a good thing as well. So educating clinicians and staff, it's sometimes you can provide face-to-face education, or there's lots of continuing education activities around stewardship. And then make sure that you have access to someone with expertise. Do you have an infectious disease doc that you can call? Or is there a pharmacist that has been trained by one of these training programs that would be okay with you calling? I'm sure if there's a hospital pharmacist near you or near your facility, maybe they would be a good someone to reach out to. If you're looking for other training opportunities, I listed them here on this slide. There's a couple different programs. The CDC has free online training for healthcare providers on antimicrobial stewardship as well. So just a couple things there. And I know I'm right at time, so I will skip our second discussion, but just think about it on your own. What are the barriers to antimicrobial stewardship in practice? And that is going to be our discussion for our next stewardship meeting. So with that, I'm going to tell you what I would like you all to do for our next meeting so that hopefully we can have a little more discussion. So for our meeting that will be in July, I would like everyone to write 2 or 3 ideas of areas your facility could possibly improve on their antimicrobial stewardship efforts. Whether, if there's something you'd really like to see, can we lower the amount of prescriptions we're writing for bronchitis? Or can we decrease the duration for UTIs that we're writing for from 10 to 7 days or 10 to 5 days based on guidelines? And then I would like you, once you have those ideas, to write barriers you think would be in your way of actually implementing any strategies you thought of. And then if you can think of how you could overcome those, that's great. But if you can't think of any ways, don't worry, we'll talk about that at our next meeting. And then bring that back so that on July 16th at noon, we can discuss some of those ideas and some of those barriers that you may be seeing.